I do, but I want to be able to see the comments. So I think it's okay. Does it bother people if we have the next slide, or?
I guess, yeah. I mean, I don't think it's necessarily a problem. If the text is big enough, it should be fine.
Okay. If not, we'll switch it out and switch it back. I mean,
okay.
I'm pretty familiar with all of it. So, all right. So, good morning, everybody. So we're going to talk about frostbite. We're a little bit late in the year for this, but you never know. And we never know where you're going to end up working one day, that's for sure. So that first slide is, actually, let me go back one, is on the way up to Denali. We're just dragging our sleds there, and this is our camp. So I've certainly been in some of these environments before, and I'd kind of like to dedicate this talk to Emmanuel Cauchy. Manu was probably the world's premier researcher in frostbite, and all of the stuff on iloprost and some of the stuff on TPA comes from him, and he's done it at the base of K2 and a number of other places. And unfortunately, while we were on our wilderness medicine elective in 2018, he went down in an avalanche just outside of Chamonix, but a super good guy. And we haven't seen a lot of new things yet. It's going to take somebody else to kind of jump in there and take over, I guess, his lab and a lot of his work. So we'll keep going. All right, so we're going to talk about cold injury. We'll talk about the epidemiology a little bit, field treatment, hospital treatment, and a little bit about rehab. So I'll try to go as quick as I can, as you can see the number of slides there. We're going to look at these things: chilblains or pernio, is another word for it, trench foot, which we definitely see that in our city, frost nip, frostbite, and the various types of frostbite. That little picture to the right is flying over on the Kahitna Glacier, and that's just glacier water and runlets there. So here we are, chilblains. So these are a category called non-freezing cold injuries. Chilblains is kind of repetitive damp, but it's no immersion involved. And it's cold, non-freezing exposure. So it's exposure to cold above, like, usually it's closer to 15 degrees, but anywhere from 0 to 15 is usually the range. The pathophys of that, there we go, I'm just going to move that up there. The pathophys of that is that it's abnormal, it's an abnormal reaction, and it's arteriolar and venular constriction. And it looks like exactly what we see in the picture. You see those sort of purplish plaques. Some people get it at the beginning of the year, and they have it kind of all through the cold season. It can get itchy if it's very bad. It can actually ulcerate. Temperate climates is more typical. And if it's really bad and there are ulcerations, it can be treated. I mean, it can be treated with amlodipine or nifedipine, usually more nifedipine in actual fact. Pentoxifylline for severe cases. The Corte cream can be used for itching, and antibiotics only if infected. So what's interesting about chilblains is that a lot of these cases, when they study them, like there's been a number of studies. There's been some, the pentoxifylline study was in Iraq over 4 winters. And the nifedipine study, I believe, was a European study. But a lot of these cases, about half of them turn out to have other pathologies. You know, when they start testing them, about half of them will have like lupus or hepatitis or HIV. There will be something else they're going to find in these patients, surprisingly enough. This usually resolves in 3 to 5 weeks. So if it's not too bad, it doesn't really need to be treated. It just needs to be kept warm and dry. But severe cases and this burning and irritating pain, then there is treatment for that. Non-freezing cold injury, the other one that's common is it's sort of more with immersion. It's usually the foot is really wet over 2 or 3 days, and it gets kind of shriveled up and skin gets soaked, and you can get skin breakdown with that. And then you can get the other things that go along with skin breakdown, various types of infections. And common in soldiers, I mean, this is certainly first described, I think it was in the Napoleonic Wars. So quite a ways back, and certainly seen in quite a bit in the First World War. And we see it in our homeless population for sure. It needs to be kept dry and warm. it can take 3 to 6 months to heal up. You want to keep it, you can use, prevention is talcum powder, Vaseline. Actually, I wouldn't necessarily recommend Vaseline to some of these guys because I think it'll just sort of muck up in their shoes in our population. And there is something, if you have really sweaty feet, called dry salt, which is quite a high concentration of aluminum chloride. So people that have hyperhidrosis of their feet can use this with some success. I guess the most easiest thing to do is have dry socks. So if you're certainly outdoors, you'd want to be changing out your socks like alternating days. And you need sleep socks for night, either no socks at night or nice big loose sleep socks that are used just for that. I can't see the question, so if there's anything pressing, I guess you could jump in there, or we can keep them for the end. Frost nip, it's a non-freezing cold injury as well. It's sort of pre-frostbite. So what these are is like ice crystals on the outside of the skin. There's no tissue loss, but it definitely signals that you're becoming really at risk for real frostbite. You get this pallor, you get paresthesias, you can get numbness. So those ice crystals are basically frost on the skin. Yeah, it's usually in exposed areas like ears, nose. A lot of times now what we use is we, on our glasses, like our glacier glasses and stuff, we have a little nose piece that goes right over the nose because the nose seems to be, we call them beaks. So, and the nose seems to be the worst place for that. And that has saved many a nose using just that little covering. Okay, here we go. So, whoops, go back one. So the pathophys of frostbite, it's still thought to be in 4 stages. You have this pre-freeze stage where you have tissue cooling. You have vasoconstriction. There's no ice crystals at that point in the tissues, but there are paresthesias and hyperesthesias from neuronal cooling. So kind of hard to tell from frost nip, really. Then there's the freeze-thaw phase where you start getting ice crystals. Now, if the tissue freezes fast, like very, very, very cold weather, like the -50 version, and skin exposure, you're going to get ice crystals intracellular. And if the freeze is slower, they tend to be more extracellular initially. Most of this stuff obviously is based on animal studies. And you get protein and lipid derangements and cell dehydration, electrolyte shifts in the tissues. So basically this initiates ischemic reperfusion injury. So once you warm this up, this is going to be a bit leaky and it's going to give you some edema and an inflammatory response. So phase 3 is a vascular stasis phase, and blood vessels vary from constriction to dilation. And what's interesting about this is you can see it in acclimatized people. They do these laser Dopplers on the fingertips, and they've taken these people, put them out in the cold, and people that are adapted actually cycle, like they actually dilate intermittently, and it takes longer to injure those people. That's been done in Eskimos in the north, and just trying to think, there's another group, but I don't have it on the tip of my tongue right now. Then there's a late ischemic phase, which you get progressive tissue ischemia and infarction. And by this point, you have the vascular shunting, you have leaking, and this is going to stimulate a cascade of mediators. Sorry, that's a typo there. So there's a vasoconstriction of the arterioles and intermittent showers of microemboli in the microvessels. And damage is definitely made worse if you refreeze and then you thaw and refreeze, because you're going to go through this whole cycle again. All right. So that's a quick summary of that. Ice crystals, constriction, stasis, vascular leak, and inflammation. So those are the 4 degrees of injury, and we'll look in a bit, we'll have some pictures of we'll look at this first here. So classification, first degree, second degree, we're talking about superficial frostbite here. the first degree, you can get a white gray plaque that almost looks like frost nip. You can see it just right there on the tip of the cock's comb right there. That's kind of a cute picture. And you can get very minimal sloughing. You might get some almost like a tiny layer of skin may come off, but for the most part, there isn't any tissue loss. When you get to the second degree, you start to get these clear blisters with kind of milky fluid. And that gets surrounded by some swelling and some erythema. And as you look further down here on the right, as it gets deeper, it gets into this subdermal vascular complex, and then you get hemorrhagic blisters. So that tells you you're getting a lot deeper here and a lot deeper in trouble. At the fourth degree, it extends into subcutaneous tissue, muscle, and bone. And we're going to see examples of all of these. So we're just talking about it for superficial frostbite. It's everything in the layer up here, and then we're in the layer down here for everything as it extends down. Okay. Are the slides okay for everybody, or do I need to make those big?
I think we can see it enough. I think it's fine.
And then you get to see my comments up there too, probably.
Exactly. Yeah.
I think it's advantageous. Should I forget something? All right. There we go. So superficial frostbite. This is not so clear. Various sorts of this is just with sort of the redness, a bit of white plaque, and this is when we start to see our clear blisters. There we go, some more clear blisters. And this is the real bad stuff, okay? Deep frostbite. Subdural injury, 3rd and 4th degree, hemorrhagic blisters. I've had a 70-year-old lady come in looking just like this, or she was like this, I should say, 24 hours later. It was much like this, except kind of wine colored instead of dark like that, after getting locked out of her home on her first date in 25 years and having a little alcohol on board. Couldn't find her keys. And so this will give you an idea, even in the field, if you have no cyanosis on the tip, the risk of amputation is low. This is basically the Cauchy classification. And you get cyanosis only on the distal phalanx, your risk is still pretty low. The minute you start to get up to the MTPs with any changes, your risk starts to go up. And as soon as you see blistering, dark blistering, and cyanosis to here and up into the carpals, you're going to lose something in those extremities. That is we'll look at this again later. And this is a 2-day classification. After 2 days, so if you're in the field and you see somebody after 2 days, and you can take a look at what are the blisters looking like on day 2 and the bone scanning, in addition to the extent of the lesion, like where it goes to. And it also gives you certain, an idea of the prognosis. So that's more of an in-hospital usually classification, although some of us are out that can be out there for days and we wouldn't get back within 2 days. All right, so let's take a look. Like, so how common is this? You know, do we see it much? Some of the studies, some of the best places to look for this are in high mountains where there are a lot of expeditions. 1,200 mountaineers a year on Denali. The National Park Service looks after life, limb, and eyesight threat. There's a pretty decent medical installation at 14,000 feet. And about 3.5% of them are treated for some version of frostbite. So in that time frame, the single most common diagnosis, and that was of anybody that was seen there, was frostbite. About 54% were on the upper extremity, 21% on the lower extremity, about 10% on the face, and in over 50% of trauma cases, there was frostbite involved. And that's a medical tent. It's actually is bigger than it looks there, but it's not super big. So a lot gets done in a very small space up there. Mount Everest Base Camp Clinic, Medical Clinic, Everest ER. So here's a little bit of the epidemiology of what's seen there. So it's obviously the world's highest peak, 800 mountaineers a year. It was started by Luan Freer, and it's now, I think this year it should be taken over for the first time by all Nepali physicians. And in that time frame, they treated this many people, at least that's what's been recorded. Frostbite was the most common reason for evacuation, and it was seen in 28% of the trauma cases. So it gives you an idea, and we certainly see it in Canada, and we'll talk about a study further down that was done actually, or a couple of case reports out of Whitehorse. Field treatment. Remind, just don't forget your wind chill charts. You should keep an eye on that. I don't know, is anybody, you can write in the chat and we'll take a look later. What happened? What do you think? Or somebody can yell it out here if they want to unmute. What do you think happened to this guy? What mistake did he make in the morning? Anybody have an answer for that?
Getting out of bed.
Well, he did a couple of things right. He had great boots and great socks and no long johns by the looks of it. So probably thought his pants were okay, maybe got snow up underneath them and wasn't paying attention to the temperature and the wind chill. He's on a skidoo. So you can picture the amount of wind involved in that, in addition to the air. So it's not just the wind chill that you look up the weather forecast on your cell or your sat phone, but it's also that skidoo, the speed. So that's just I throw that in here. That's like Mount Foraker from 14,000 foot. Looking straight out, that's a lenticular cloud there. If you see that on top of the mountain, you do not go there. There's high winds up there, but it's just a gorgeous view. A good place to camp right in here on the saddle. All right, so busy slide, but it's a pretty good summary. What do we do for prevention and field treatment of frostbite? Well, you're going to treat, if there's hypothermia, that's life-threatening. You're going to treat that first, life before limb, and you can treat it at the same time, actually. So you're going to remove anything tight, clothing, jewelry, rapid rewarm if you can keep it thawed, right? It has to be protected from refreezing. If not, you can walk on a frozen limb. It's not ideal, but if you have to, and that's your way out to survive, and you can't get evacuated any other way, that's the way to go. So some of these recommendations, like hydration, is a 1C recommendation now. They recommend, like, if you have a small bags of fluid, like at a base camp, and you have a way to warm them up, even if it's in your jacket, and make sure they're good and warm, and small boluses of 250 cc's. And if you're you could be an expedition doc and have access to this. There's some discussion about low molecular weight dextran, but there haven't been really any good case studies about that. That's mostly lab stuff, even though it's in the Wilderness Medicine Society guidelines. But I looked to try to find cases for that, and I could not. Exercise initially, if you feel for prevention, is good. It's a 1B recommendation. So if you can heat up, there's definitely studies that show that you can decrease the level of frostbite. They've had people actually go out into groups and do this. Hand and foot warmers do work, unlike the guy that was guiding us on the night that made us throw away all our hand and foot warmers before we went up because it was extra weight. Don't do that if you go out. And people have electronic or electric or battery operated foot warmers and insoles, all kinds of things these days. And they're helpful. You don't want to put it next to the skin and stand on it in case it breaks open, but you put it between the sock and the boot. And sometimes one of the things that seems to be helpful, sort of behind your malleolus, right where your posterior tibial artery kind of goes. For some people that seems to work. Having a second pair of gloves inside your jacket and swapping them in and out, This seems all like basic stuff, but it's good to think about. Bulky dressings, you see that marked everywhere. That's only if it fits easily. Like if you have frozen toes, you probably are not going to, if you thaw them out, first of all, you may not be able to get the boot back on. And adding a bulky dressing may not be helpful because you may have increased compression and more tissue damage. So 2C is a bit of a stretch, I think, for the bulky dressing thing. Ibuprofen is good just because of all the mediators involved, and this has been fairly well studied. And the standard dosing is 600 twice a day, or it can be up to four times a day. They say roughly 12 mg per kilo, but the max is 4 times a day, 600. You elevate is good. If you have to thaw it over, you can't evacuate right away. Aloe vera is a 2C recommendation. Usually that's used in frostbite. Like if you have some blisters and they've just on roof, like especially the clear ones where you're going to keep going on your hands, you can put aloe vera on that and dress it up with non-stick dressing, and it seems to help. And all of this is painful, as you can imagine. So having some analgesia is certainly a good idea. So if you're going to rewarm, rapid rewarming has been well studied. It's the best way to go. 37 to 39 degrees. The whole chlorhexidine thing in the water, that's still in the recommendations, but there's no real good study that says that's of any advantage. There's no double blind anything for that. Yeah, basic stuff. It won't harm. Passive thaw if rapid rewarming is not available. You do what you can. And like I said, for pain control, you'd want NSAIDs and opiates. If we're out there, we always carry some opiates just in case for multiple reasons for that. Blisters, we don't tend to on-roof those unless they're in the way. If they're in the way over joints and you have to, use your ice axe or use your pole like to get out of somewhere. I mean, you need to function. Then yeah, you're gonna just aspirate those and some aloe and dress them. That's the pathophysiology of the I don't think there's any news there. And that's the mechanism of action of the aloe vera. It basically reduces the thromboxane and prostaglandin formation. And it's synergistic with the NSAIDs. 2C recommendation. Hyperbaric oxygen hasn't really been shown to help. Oxygen may help if you're at very high altitude and if you're hypoxemic. Hyperbaric oxygen may have some vasoconstriction. I think that's why there's some question about using hyperbaric oxygen, but that may work if you're very hypoxemic at high altitude. So it depends on where you are when this happens. If you're on sea level, probably not. If you're at altitude, yes, it may help. Antibiotics it's in the WMS guidelines, but they sort of say it's a 2C recommendation, or a 1C recommendation, which is again a bit of a stretch, I think, because what they say is for if there is evidence of infection. So if there's no evidence of infection, there's no reason to be giving antibiotics for these. And there's no real good evidence of medical or surgical sympathectomy. So to elevate a limb, it's helpful, 1C, TET-Tox 1C. And if there's a fascia, you may need to do a fasciotomy. That's more an in-hospital, less likely a field procedure. If you feel there's a compartment syndrome, that may be because there's a lot of tissue involved, not just a few toes. I've not seen any cases where that's been done in the field. Not read any. This is kite skier's toe. I don't know if anybody's seen that. There's an article out on this. This happens because it may not be so cold, but you get the compression. So already you're getting vascular stasis and vasoconstriction, and your boots pushing on the toe because you're putting pressure on that. When you're putting a weight on your skis and you're turning your skis with the kite, you have a lot of acceleration right into that tissue. So it's a well-known phenomenon. All right, so let's head off into hospital treatment. So when they come out of the system, out to us, or when we're working in the more civilized area, we have a few more options. And this is all in the past 10 years that this has sort of been on the table. Thrombolytics are 1C recommendation. That's within 24 hours. But we'll see on one of the upcoming slides, the sooner the better. There are vasodilators such as iloprost. Imaging can be helpful, angiography. And amputation is late. It can be months out by the time this declares itself. And there are other complications. They can get infected. They can get gangrenous. And it's good to have an expert surgeon, and it's good to have people looking after these that are used to looking after these. So just a quick reminder about the prognosis when you see these. So that's a quick and dirty evaluation of what you can expect. And technetium scanning is what, when they say bone scanning, here is what this is. I'll just give you a minute because I didn't the first time, just to take a look at the table. Okay. So TPA, they're the clot buster used in myocardial infarction and ischemic stroke, excuse me. And we certainly don't use it in the field in trauma, but this has been used in hospital and it has been used in the field in 3rd and 4th degree frostbite for limb salvage. So this study came out in 2005. They had 18 patients and they gave TPA IV 13 and intra-arterial in 6. They felt the IV was actually safer and just as effective. No difference in efficacy. They had a 19% amputation rate. And they didn't really have, on that particular study, they didn't have really control group. But historically, the amputation rate for these things have been up as high as like 40%. And that was the dosing that was used. So there's been an algorithm now that since 2010 they're using as a rapid rewarm. They assess clinical and Doppler flow. This is in, I think this is in Hennepin County. They scan it, and if it's less than 24 hours, they give the TPA. And the way to give it is a 3 milligram bolus. So 30 mLs of 0.1 milligram per ml. And then 1 milligram per hour. You consult the surgical people that you need to, or the plastics people, whoever's the expert person for this. And they'll decide how long they want to run this infusion. Usually it's run with concurrent heparin at 500 units an hour. So TPA and frostbite. This is an idea of what we're looking at here and what it can look like on the scan. We have some better scans. So this is what it looked like initially. This is what it looked like after TPA, and this is the technetium scan after. So look, before and after. So I think that's pretty amazing, actually. Utah, they did another study 2 years later. Again, these are not great numbers, as you can tell. We have a few numbers. So in 2007, 6 patients got intra-arterial TPA. The amputation rate in their historical past was 41%, went down to 10%. The only complication that the other study didn't talk about complications. This had 1 retroperitoneal hematoma, which was not life-threatening. Caused some abdominal pain. And this is pre-TPA, post-TPA. Pre-TPA, post-TPA. I think there's, a picture's worth 1,000 words, I think, here. Pre-TPA, post-TPA. There we go. So the indications for this, so are only deep injuries. I mean, the 1st and 2nd degree frostbite, certainly you wouldn't be doing this. I mean, the risks and it's a risk-benefit thing. So deep extending proximal to the PIPs, that's usually the scenario. Big toes are important. Even if the whole foot or the metatarsals are not involved, just because it's so involved in our walking, our weight bearing, and all the activities people do. it has a, they'll do it for big toes sometimes. We're going to keep going. Ideally, angiography and scan angiography pre-TPA. Adjunct heparin. Heparin alone has not been shown to be effective. And Hennepin County, that was in 2010, I believe, that they said their best results were if it was done within 12 hours. And every hour that they delayed it from the time that they received them, it was worse by about, they said 28%. So I don't know exactly how they calculate that 28%, because 4 hours would be 100, or if it was 28% of residual. I'm really not sure. But it was for grade 3 and above. So this is really interesting. This is a study from 2011 with iloprost, which is pretty amazing stuff. It's a synthetic prostacyclin, essentially. The study, they had 3 groups. They had 47 patients. They had another vasodilator. It's not really something that we have in North America, and aspirin in one group, and they had a 45% amputation rate. They had prostacyclin plus TPA plus control, and they had a 5% amputation rate. But the prostacyclin alone, and when I say control management, like aspirin or that would have been like aspirin or NSAIDs, that was pretty much what control management would have been. They had no amputations. So very impressive. And that has been repeated since. And it can be used like greater than 24 hours after thawing with some effect. So out to about 48 hours. So if you have a down small plane, a down helicopter, those people that get out, that take a long time to get out, and fewer side effects, fewer risks actually associated with this. It was stopped in 3 of 81 patients, and that was, 1 was for palpitations and 2 was for nausea and vomiting, which could be controlled, so pretty safe. So it's a 5-day protocol, and day 1 to 3, you go with like the 0.5 nanograms per kilo per minute, and you go up as high as 2 nanograms. That's the max that you go. Some people get headaches, flushing, they might get a bit of dizziness. So you're going to judge the max is 2, you start at 0.5, you see where you get. And then whatever the maximum tolerated dose is, you start at that for days 4 and 5. I'll just, if you want to read the notes on the right, just gives a little bit of detail about how this stuff works. It all has to do with cyclic AMP. It's a combination of, it works on vasodilation, it works on endothelial cells, and it works on platelets to make them less sticky. So a couple of different things there. So this is from 2016. There's a Yukon Arctic, little typo there, Yukon Arctic ultra race, which is 100 miles, I think, 100 kilometers, 100 miles, I'm not sure. And this first patient was out for 24 hours, minus 40 to minus 50 degrees centigrade, and was airlifted back. And the core temperature, you can see initially was fine, was not hypothermic, not really significantly hypothermic, 36.8, grade 3 frostbite, and had a lot of things done. He was rewarmed. It was rewarmed at 38 degrees C water. They did put the chlorhexidine in it. He did have clear blisters, was given fentanyl and morphine for pain control, was given ibuprofen 600 4 times a day. The clear blisters were aspirated, and aloe was applied. It's like they did the full meal deal here. And an adaptic equivalent dressing, so something porous nonstick dressing was applied. And then they were given iloprost to 2 nanograms per kilo for 5 days. And the only thing that the guy had afterwards was residual hypersensitivity to touch about 6 months later. That's pretty amazing. Pretty nasty looking here, and looks pretty great here. Same race. This guy, I guess, is a bit of a tough character. So -30 to -60 degrees. He was out there for 64 hours. He finished the race, this 100-mile race, went straight to the hotel and got his feet and got in the hot tub. Excuse me, it says hot tub there. A hot tub in the hotel. And I don't know if there was any rum or alcohol involved, but usually there's some celebration at the end of these. And so then finally he realized, his toes were numb and white. So he goes to the ER, and it just goes to show you how you can have people with more or less experience when you go there. So he was given Keflex and he was sent home. But the next day he said, my toes are really bad. That's my big toe. I want to do this again. I want to, be active. I want to maximize my, my outcome. And he probably got wind of that his buddy there got something else when he went to the ED. So he goes back, and then he gets also pretty much the same recipe for one day, but his flight was going out. So he did miss a day on the way out. Wherever they laid over, there was no Illiprost because there is none in North America officially. We can talk about how to get it. But when he got home, he did get it on day 3, 4, and 5, and 6. He did get 5 total days. And about 6 months later, he climbed Mount Olympus in trail shoes. He can't really ice climb anymore because of the toe tip sensitivity, and he can't kick a ball. So not too bad. If you look at the mess that toe is in, it looked like there wasn't going to be a lot left of tissue, but actually it salvaged all the tissue in the toe. Pretty amazing. It didn't even, looks like the nail grew back in 6 months, everything. So do we see it in Canada? This was like a retrospective chart analysis of Whitehorse General Hospital for 10 years, average of 14 patients per year, presented to the ED there with frostbite. 25 patients over the 10 years presented with severe frostbite, grade 3 or 4, and 6 of those were pretty advanced and required amputation. So, and that doesn't say how many digits were amputated. That just means like that's the number of patients that had an amputation. They may have had multiple amputations. Let's go. So that's our guy. Let's see how he ended up. Well, unfortunately, this is what happens if you don't get any of those. You don't get TPA. You don't get out quick enough. You don't get any Illiprost. That was his scan, and that was his result, unfortunately. So it begs us to be ready and to know about this and make sure that we can handle this with the appropriate medications in a timely fashion. I'm going to do just a few slides on rehab. They can do amazing things now, tendon transfers, fingers to thumb transfers, toe to thumb, like all kinds of things can be done. Toe transfer is complex, but it can be done because the thumb loss is pretty devastating. There's inserts in shoes that make it a lot easier to walk with and in a normal fashion. This guy, I don't know if anybody out there knows him. I remember him. I remember him when he had 2 legs. And I remember him a few years later. I hadn't been down in the Whites for a while. I guess it was overseas probably. And he went out ice climbing. That's Hugh Herr. He does TED Talks, actually. He was 18. He was out climbing in the winter, top shape, excellent climber, got out in a storm. Him and his buddy got disoriented. And there's a team went out looking for them. And actually the team got avalanched and one of the rescuers died in that rescue. And 3 days after they went lost, they were accidentally found by some snowshoers. And so they survived. They were close to death. They survived, and he lost both legs. And I sort of heard that story a bit after the fact because I was going down there to climb, and this guy zoomed by me on a bike, and I realized he had no legs. And this is Hugh. So he climbs, he says, harder than he did even before. And he is now a biomedical engineer at MIT, designs special limbs that have all kinds of computerized controls and stuff. Pretty amazing guy and does TED Talks. But you don't want to ever get here. So some take-home points: rapid rewarm, prevent refreeze, prevent this from the get-go. NSAIDs and aloe vera can help in less serious cases. Consider TPA and iloprost for deep frostbite. Telemedicine, these days we should be able to get that from almost anywhere in the world for consult. And delay amputation. It's months out before any amputation is going to take place. Although technology is getting better, than we know sooner, based on some of these scans and so on. Because some people don't want to have 6 months of this when they think they're pretty sure already that they're going to lose a specific amount of tissue. But usually it's several months, 2 or 3 months for sure, sometimes longer. Okay, so I'm going to unshare, stop share. Here we go. No layers on the legs, right on. So, so questions, anybody, shoot.
There's one question there, whether kite skier's toe is treated the same as a frostbite.
Yes.
Yeah. Okay.
Yeah.
If anyone has any other comments or questions.
Sorry, you mentioned that the iloprost is not available in Canada. Is that what you said?
Yeah, so look, so here's the deal with that. Actually, that's really important that you brought that up. Some of us, I order stuff, special access medications for another job I have, off and on, all the time, even this week. So it can be got, and this is how the guys on Whitehorse got it. So special access, Health Canada. I think, I can't imagine, we should have it in Montreal, maybe not where I'm working now. Should we have it at a tertiary care center? I would think so, especially if you're going to get anybody flown down from up north. I don't even know in Montreal if I don't know what's happening to these because we don't have a good record of them. Like, should they go to the burn center? I would expect that there should be a center of expertise for this, in Quebec. And so wherever they're going to go, they should fill out a special access form, very easily done with the pharmacist. They're used to doing this all the time. And you ask for it and you use the data, like we see so many cases a year, or we're responsible for the evacuations from up north. There's a whole section of justification, but I think it's very easy to justify. And you can procure the iloprost. Flolan hasn't been studied, just so you know, and I think it's because we know we have something that works and works in much the same way. So that's my answer to that. My second half to that is that some of us have been talking with our colleagues elsewhere in Canada, especially in the north, about having a frostbite registry in Canada. So we have some kind of standard to go by to know where we are, to get enough cases to really look at some of these other things in more detail, because the numbers are small, and all these recommendations of 1B, 1C, on small numbers, some things seem to really work well, but I don't know if we have all the answers at all yet.
Great. Thank you so much, Heather.
Yeah.
Doesn't look like we have any more questions.
Everybody's hungry. Me too.
Great.
All right.
Okay, guys. So that's the end of rounds. Thank you all for joining this morning. It will be rounds again next week on March the 10th. So hopefully see you all there.